Dr. Megan Riddle, who's going to be talking about eating disorders and specifically strategies that you can use while they're inpatient, while these patients are inpatient, to help treat.
All right, guys, well, thank you so much for having me today. This is a topic that's really very near and dear to my heart and that I do a lot of teaching on for the residents and the med students, so I'm really excited to have the opportunity to come and talk with you guys about eating disorders, because I think it's a subject that none of us get a lot of good education on, and when these patients hit the unit, they are usually very sick and can feel pretty challenging to take care of. So we're going to talk about quite a bit today. Also, just to mention, so I'm the chief resident here and I'm quite reachable, so if you have questions afterwards, please feel free to contact me. I'm happy to talk about eating disorders all the time, every day. So we've got several objectives. First of all, we're going to talk about why it's even important to be having this conversation and why we need to be identifying these patients early, helping them get into treatment, and really talking about this subject at all. We'll talk about the different components of treatment for eating disorders and sort of what all is involved. We'll also discuss some of the interventions that you guys can be thinking about on the inpatient psychiatry unit. And then finally, we'll talk about recovery, because I think for a lot of us, we'll see these patients at their sickest and sort of have this sense that, recovery is impossible, nobody ever gets better. And that's really not the truth. Most of these patients do indeed recover. So why should we be talking about eating disorders? Well, first of all, eating disorders have a high morbidity and mortality. So fatality there's increased risk of death, thanks Tim, across all eating disorders as a result of both increased rates of suicide as well as medical complications. And of all mental illnesses, anorexia is one of the disorders with the highest fatality rate. It's beat out only by opiate use disorders at this point. So this is a highly fatal disorders. Also relatively common. So actually some 30 million people in the US struggle with eating disorders at any given time. And interestingly enough, if you look at the adolescent population, very common in this group. So it's actually the third most common chronic condition in adolescents, behind only obesity and asthma. And my guess is a lot of those obesity cases also have some eating disordered behaviors thrown in there as well. And like I said, there's sort of this idea that maybe we don't need to talk about eating disorders because they're really rare, but they actually have a prevalence on par with many of the disorders that we see all the time. So if you look at binge eating, bulimia, anorexia, you're looking at prevalence rates between 1% and 3% in the general population, which is really common, which is really comparable to schizophrenia, OCD, and bipolar. And actually, if you look in groups of patients that we see all the time, rates are quite a bit increased. So there isn't good data, actually, I've looked all over, for rates of eating disorders in an inpatient psychiatric unit, but there is some data in the outpatient setting. So if you look at an outpatient clinic, outpatient psychiatry clinic for patients being treated for anxiety or depression, rates of eating disorders are around 7%. If you look just at women in that group, rates are 14%. And then one study which looked at women in an intensive outpatient program who also had personality disorders, eating disorders were actually 17% of that population. So really common in some groups of patients with the psychiatric issues that we are seeing all the time. We also need to be talking about eating disorders because these patients are falling through the cracks. We have preconceived notions about what an eating disorder patient looks like. This is based on, gender, ethnicity, body type, age. And the truth of the matter is that eating disorders span nationalities, both genders can have them, and people of all different ages. There's actually some data to suggest some 13% of women over 50 have some pretty significant eating disordered behaviors. So it's really not just young white women, which tends to be the picture we have in our head. we're also just missing these patients. They are falling through the cracks. So for patients with bulimia, only 1 in 10 actually get identified by their healthcare provider. And because of that, people don't get funneled into treatment and then end up having this eating disorder that sort of lingers for years. And that's a problem because although we don't have great data, honestly, about eating disorder treatment, it does consistently show that earlier treatment is associated with better outcomes. So we do actually need to be addressing these issues. What sort of contributes to the development of eating disorders? So eating disorders are basically, like the rest of our mental illnesses, a combination of biological, psychological, and social factors that contribute to this. So we definitely live in a thin is beautiful culture where, you know, being fit is better. There's a lot of societal pressure to have a certain body type, a certain appearance. And yet it's interesting because while like 50% of the nation any given year goes on a diet, if you look at the actual prevalence of eating disorders, not everyone who diets develops an eating disorder, clearly. So there must be some other factors at play. And we do actually know that genetics plays a pretty strong role in the development of eating disorders. There's thought to be variations in various neurotransmitters, serotonin and dopamine. There's also maybe changes in systems that drive appetite and that drive reward. Although I do want to emphasize that eating disorders really aren't a lack of appetite. Like patients with anorexia are often like very hungry a lot of the time, which I think is a misperception that people have about this disorder. And then finally, there's a lot of individual psychological factors that come into play. A lot of these folks have a trauma history, sort of like our personality disordered folks. Often they came from chaotic childhood. Sexual abuse is not uncommon in this population, although certainly not true for every individual with an eating disorder. Personality definitely plays a role. You see a lot of avoidant, perfectionistic individuals, also sort of increased rates of some cluster B traits, histrionic and borderline. And then finally, comorbid psychiatric issues. There's high rates of anxiety in these populations. Often the anxiety actually precedes the development of the eating disorder. And so there's some thought that some of that anxiety may actually be driving the development of their eating disorder. It's a little bit of a chicken or the egg situation, but that's one of the hypotheses. We're now going to take a quick tour through the different eating disorders. Some of these diagnoses you've probably heard of, some you may not have. So the two that you're probably most familiar with are anorexia and bulimia. Diagnoses have been around the longest. So for anorexia, you see this restriction of energy intake leading to significantly low body weight. Typically we define that as like a BMI less than like 18, 18.5. This is coupled with a really intense fear of weight gain or behaviors that interfere with weight gain. Sometimes you get patients that are like, oh no, yeah, I know I need to gain weight, like that's, yeah, of course I'm too skinny now, and yet they just won't eat more. And so that still meets criteria. And then they have excess concerns about shape and weight. In bulimia, you have these recurrent binge episodes where they're eating an excess amount of food in a discrete period of time. Typically, they feel pretty out of control when they're doing that. And then they're also engaging in some sort of compensatory behavior to try to offset the weight gain. So they're doing something to purge. They're vomiting, they're using diuretics, they're using laxatives. Some people exercise excessively. Actually, that can be the form of purging for some folks. And it occurs pretty frequently, so they're doing this like at least weekly for at least 3 months. And they, like patients with anorexia, also have these excess shape and weight concerns. Two disorders that you might be less familiar with, they're new to the DSM-5, are binge eating disorder and this mouthful called avoidant and restrictive food intake disorder, or ARFID for short. Binge eating disorder, very similar to bulimia. You're getting these recurrent binge episodes, again happening at least weekly for at least 3 months, but they're not engaging in any sort of regular repetitive behavior in order to try to prevent the weight gain. I would note, interestingly, for patients with bulimia who are doing some form of purging, often the purging still doesn't offset the caloric intake, and they often have gained weight, sort of despite their best efforts otherwise. ARFID is a little bit of a
funny beast. So it's an eating disturbance, typically a restriction leading to one of the following. They have weight loss, they have nutritional deficiency, they might be dependent on tube feeds or supplementation of some sort, and it's causing them significant psychosocial distress. And if you look at this, you might think, well, that sounds a lot like anorexia, right? They're like not eating enough, they're losing a bunch of weight, we're tube feeding them. How is this different? And so this is different in that it depends on sort of the motivation behind the restriction. So whereas in anorexia, it's much more related to body weight and shape, for these folks, it much more has to do with kind of the nature of the food itself. So its texture, the way it tastes, the way they feel after they eat it. So you see increased rates in patients with autism, for example, high anxiety, OCD. I'm also doing some research in patients with functional GI disorders, so like IBS, and you see this in them as well. Orthorexia, which is sometimes a word thrown around in the lay press, which is sort of people who are obsessional about kind of healthy eating, all organic, clean eating that can go to sort of a pathological level, they would actually fit more in this category than say in a typical anorexia category. Then our two sort of grab bag diagnoses, just like we have for anxiety and depressive disorders, are other specified feeding and eating disorder and then unspecified eating disorder. So I really like to bring up this other specified feeding and eating disorder because basically these are patients who are doing something funky with their diet. It's causing them distress, but they don't actually meet full diagnostic criteria for the other stuff. So a good example would be atypical anorexia. And this is a patient I saw intern year when I was in the UW-ED. She'd fainted at a Husky game. She probably had a BMI in the mid-30s. But when you talked to her, you realized that she'd been restricting her diet for quite some time to like not that many 100 calories a day, and had lost a lot of weight, had all the sort of cognitive thought processes you get with anorexia, but didn't meet full criteria, right? Because she's lost a bunch of weight, but she started at an elevated weight. So she still doesn't meet criteria, but you can sort of put her in this category. She'd be someone I'd really want to get her into treatment, even though she doesn't actually meet criteria for anorexia, right? Because we are headed not a good direction with her, and she's already in the ED. And then unspecified eating disorder, just like our unspecified mood and anxiety disorders, you're like, there's something weird with their eating, but either they won't tell you really what's going on, or you're just not sure. That's sort of this default. But we know that patients are a lot more than just their diagnostic label, right? And it's important to understand sort of the individual experience of their eating disorder and be able to kind of have a conversation with them about it, because that can really establish rapport and also impact our treatment and how we approach the patient. And it's really important to actually be bringing this up with our patients and be talking with them about it, because they're not going to bring it up themselves. There's a lot of shame around eating disorders. They really don't want to share this with you. I just left. I have a DBT patient who has a big binge eating disorder issue, and a big topic of our session today was the amount of shame that she feels about the fact that she can't control her behavior around her food, and how hard it is for her to admit, even to me, her like individual therapist who is not judging her about this and is really glad she's sharing it with me. It still provokes a lot of shame for her. So she's certainly not going to volunteer it to another provider who's not specifically asking her, because she doesn't want to be judged about it. This can also be what we term an ego-syntonic illness, because on some level the eating disorder is working for them. If you can spend all of your sort of energy and focus thinking about what you're going to eat, when you're going to eat it, when you're going to exercise, how you're going to avoid eating dinner, you don't have the mental time or energy to think about all the other things in your life that feel kind of scary and overwhelming. So it really lets you focus on something that's really concrete that you can control. And so for a lot of our patients, it does sort of serve this purpose. When I'm starting a conversation with someone about eating disorder, it's not necessarily an easy task, and it can sometimes be hard to come up with like the right words to even broach the topic. So I typically try to start by normalizing it. And I'll say something like, you know, when people are under a lot of stress, they might eat more or less than usual. Does this happen to you? And I think for most of us, like, we either like eat when we're upset or don't eat breakfast when we're anxious before an exam. So that's a really like normal human experience, which they've kind of taken to an extreme. Then I start asking them questions sort of in three main categories. So I'm going to ask them about their eating behaviors, their purging behaviors, and issues around their body shape and weight. And while a lot of these questions are sort of the focus of my more like diagnostic assessment interview, I think it also gives you some ideas about things that you can be talking with them about on the inpatient unit, things that you can be asking about and inquiring about. So things related to eating behaviors, I'll have them like walk me through a typical day, tell me what they usually eat. Are other people concerned with what they've been eating? And sort of how do they feel about their diet? Purging behaviors, I'll just kind of get down to the details, sort of like what are they doing, how often, how do they feel when they do it. I really focus on exercise quite a bit because for some folks this can fly under the radar because our culture like really supports obsessive exercise. I had one patient who explained to me, I asked her what her exercise routine was, and she was like, well, every morning I get up and I go for a like 5-mile run, and then I do an hour of yoga, and then I go hiking. And I'm like, that seems like a lot. And so often I'll say, so what happens, like, I mean, great, I'm glad you're active, but like what happens on days you can't do all of that? Because presumably that can't happen every day. And she stops and she looks me square in the face and she says, that never happens. And like, then you know there's a problem, right? That this has become obsessional and is like way too important to her if she can't adjust that particular exercise schedule. Right, exactly. Like,
you have time to work.
Totally, and this is, eating disorders can do this to patients. Like, they prioritize their eating disorder over the rest of their life, and so, you know, friends fall away. Mm-hmm. And I would say that athletes are definitely increased rates for eating disorders, so it is an issue amongst the competitive athletes as well, for sure. There was actually just recently in the news a couple of figure skaters. The Russian gold medalist for 2014 was in treatment and got out of figure skating because it was not, my guess is the conversation was that it just wasn't compatible with her actually being healthy around food and exercise. And then the last thing one thing that I am always talking with them about is this whole idea of the life impact. Like, how is their eating disorder actually affecting their life? What's their level of insight around that? It's a lot sort of in the MI, motivational interviewing vein. Where are they with regards to interest in changing their behavior around this? One question that I really like asking is, how is this helpful? It usually surprises them that I'm willing to acknowledge the fact that the eating disorder is helpful, and it sort of aids in building rapport and can also give you some interesting insight into how they understand their eating disorder and sort of what its role is for them in their life. Just wanted to talk briefly about rapport, because these can be difficult conversations to have with incredibly difficult patients to work with, particularly in those who are in pretty heavy denial about the severity of their illness. And it's really important that you approach them just like you would the rest of your psych patients, with a lot of, you know, genuine warmth and empathy, while also kind of leaving judgment at the door. It's important to sort of check your own emotional reactions, because we all have preconceived notions about patients with eating disorders, and we also all have our own stuff about our own body image, relationship with food, that can really impact how we interact with these folks. The first time I gave this talk was actually to a bunch of interns, and I got a lot of questions with regards to, like, what could they ask, what could they not ask, sort of like this walking on eggshells around an eating disorder patient approach. And although these patients appear super fragile, they are not necessarily that any more fragile than the rest of our patients with regards to things to say, but I do think that it's helpful to know some general parameters, because you can accidentally stick your foot in your mouth kind of easily. So first of all, do share your concern with the patient. If you are worried about them, you should definitely be telling them, hey, you know, you've lost weight, like we are worried. We're worried about this eating disorder, because for most patients, they have some kernel of worry themselves, and you kind kind of want to foster that, so they can acknowledge the fact that, yeah, something is not right here. This is not working for me. It's so important to validate their feelings. There's a lot of distress that goes on around talking about eating disorders, treating the eating disorder, and so this is a great opportunity to sort of practice your validation and empathy. Focusing on skills, seeing how they can address those feelings. When you're feeling this way, what sort of things are helpful in these situations, and getting them looking for things other than their relationship with food to do that. And then also simply talking with patients. That girl I mentioned with the BMI of 14, she said one of the more helpful things that had happened to her was a medical provider had just sat down with her and been like, hey, tell me about your eating disorder, what's that like? And just really had listened intently to her. In terms of don'ts, please don't reduce this to you just need to eat more. You will lose the patient then, and you will probably never get that rapport back. You are right. On some level, the underweight patients, that is indeed exactly what they need to do. But if you say this, that's kind of the end. Also, if you have the opportunity to see a patient sort of recover over time, please avoid weight and shape comments as this happens. And you're probably thinking, well, of course, I'm not stupid, I won't say anything about this. But what you interpret as a weight and shape comment and what these patients interpret as a weight and shape comment are two very different things. So things like, you look good and you look so much healthier are simply heard as, you've gained so much weight and you're fat. Yeah. Or this whole idea of, if you look healthier, it means you've gained weight. And then finally, don't forget, this is a mental illness, not a choice. Nobody woke up in the morning and thought, I think I'll be bulimic today. That's just, people don't choose these disorders, as we saw through sort of the genetics component of things. So now we're going to shift gears a little bit and talk about treatment. So treatment of eating disorders is truly a team sport, which is why I was so happy when Tim offered me the opportunity to come talk to you guys, because it's the psychiatrists by themselves, we can't do this on our own. It really involves everybody on the treatment team in order to get these patients doing better. So we all have a role to play here. Treatment can occur in a number of different settings, driven by several factors. So how medically stable they are, what sort of other psychiatric issues are going on, and how willing are they to engage in treatment. So this is sort of by order of illness severity. So by the time we're seeing them on the inpatient medical or psychiatric wards, we are seeing sort of the sickest of the sick. And ideally, most patients are treated down here where they're typically more specialized in treating eating disorders. So I encourage, once a patient is psychiatrically stable enough to move, say, to a residential treatment program, that happens, because it's just, that's their focus, right? Which we can't have on the inpatient psychiatric unit. But we'll talk about what we can do on the inpatient unit. So I've broken treatment down into 4 components. So we're going to talk about weight restoration, addressing eating disordered behaviors, psychotherapy, and then the role for medications. This is kind of a Sisyphean battle. You're constantly pushing the boulder up the hill, only to then be chasing it back down again, which is why it's so important that it's a team sport, so you're not the only one chasing the boulder and trying to get them better, because that's just exhausting. And these are honestly kind of exhausting patients. They're my favorite, but they're exhausting. So weight restoration, what does that look like? Ideally, we want them eating all of these calories. We don't want to be doing the NG tube route. We want to be sort of normalizing their food behaviors. Like Tim said, a big part of this can be exposure. So that's lots of meals, 3 meals a day, 3 snacks a day. Typically, we're offering some sort of replacement if they're not eating their full meal, so Boost or Breeze. It's interesting because for some patients, it is much easier to chug down a can of Boost than to go through sort of the emotional distress that comes from working their way through the whole hamburger. So some patients would rather opt for the other replacement. Collaborating with a nutritionist or registered dietitian at this point is really important. They can do psychoeducation, support, and work around the meal plans with the patient, and then you don't have to be the one negotiating every single meal, because there's a larger plan that the patient can be reminded of, so it's not always just you. With regards to eating disorder behaviors, these patients come with a whole slew of disordered stuff around their eating disorder. They usually have like these huge lists of unsafe foods and like 3 foods that they're willing to eat. There's lots of food allergies. There aren't allergies. Many of them have been to a naturopath who is like added to the food allergy list in a very unhelpful way, because they'll say, I feel bloated after I eat. And I'm like, oh yeah, that's because you're not eating. Issues around portioning, pacing, all of these things. Lots of rituals around meals, like whether that's like cutting up food into tiny pieces or having an order to things. So lots of weird stuff goes on when they actually are trying to eat. So what do we do? This is the exposure component. So there's really structured meal plans, which the goal is to expand both the variety and the quantity of the food they're eating. Also, we're providing support and accountability around meals. So if they're in the outpatient setting, they're keeping a food record, they're recruiting family members to sort of keep them accountable. In the intensive outpatient, partial hospital, or residential programs, there's someone like sitting there with them when they eat, to sort of like normalize table behavior, help distract them, sort of cheerlead them through the meal. And then that can also happen in the outpatient setting. We also have exposures to things that you might not necessarily think about, like going to restaurants and ordering something off the menu that isn't salad with no dressing. Going to the grocery store and not being allowed to spend an hour to look for the lowest calorie bread. You just have to go in there, buy something, and leave. And then cooking and not knowing exactly what all is in the meal are important things to also have as part of this recovery process. And then if their weight is healthy enough, to have a plan around allowable exercise, because we do want them to be able to do that, but in a healthful, non-obsessional way that does not take up their entire day. With regards to psychotherapy, if you look at anorexia, the data doesn't point to one particular therapy in particular, but it does show that nutritional counseling plus therapy is better than nutritional counseling alone. So it's sort of dealer's choice. Whatever they are kind of willing to engage in is good, and we should have them involved in that. So CBT, interpersonal therapy, there's evidence for DBT, mindfulness. All of these things can be helpful for these patients. With regards to bulimia and binge eating disorder, the data is more clear. So consistently it shows that CBT is the best intervention, and we'll talk a little more about this. Then finally, to talk briefly about medications. So for anorexia, the news is not great. Meds are typically pretty ineffective when the patient is in the low weight state. It's just not really going to help them. We start them anyways, but it really doesn't help at that stage in the game. There aren't any FDA approved meds. There's some evidence that SSRIs can help prevent relapse once they are at a stable weight. We often try antipsychotics because we're like, oh, weight gain is a side effect, and some of their thought process really borders on the psychotic, if not totally crosses that line. But like, you try giving an eating disorder patient something whose side effect is weight gain, and you will wage an epic battle. They won't take it. And even if they do take it, they don't tend to have that side effect. Like, they are the one exception to the antipsychotic weight gain rule. For bulimia, data is again better and more consistent. So SSRIs are first line. Prozac is actually FDA approved. You want to avoid bupropion because there's increased seizure risk. And then binge eating disorder, SSRIs are again the first answer. And then lisdexamfetamine or Vyvanse, which is a stimulant, is actually FDA approved and seems to help with weight loss and decrease binges. One could imagine, it's a stimulant, so it makes sense that it helps with weight loss. Why it decreases binges? Maybe some appetite suppression. That's not super clear either. A lot of hand waving in this field, even more so for eating disorders. And so really the bottom line is, for a lot of these patients, it's not the meds that are the answer. It's much more the therapy. Meds can be adjunctive, they can be helpful, but yeah, answer's not going to be in the Pyxis. So what are we talking about? We're talking about comorbid psychiatric issues. So this is an admittedly kind of confusing chart. So the blue is anorexia, the green is bulimia, and the purple is binge eating disorder. And so these are patients with an eating disorder. If you look, between 60 and 75% of them have another psychiatric issue in addition to their eating disorder. It can be mood disorders, anxiety disorders, substance use, PTSD, sort of increased across all of these patients. And I think it's important to recognize that while the eating disorder might not be the primary reason why they're admitted to, the 5 West units, it probably is playing a big role in the other stuff going on. So we want to kind of not lose sight of it, and focus entirely on this comorbid stuff. And then on the flip side, these other stuff need to be treated if you're going to really address the eating disorder. So on the psychiatric unit, some things to think about. So these patients are at increased risk of suicide, both patients with bulimia and anorexia. So relatively speaking, patients with bulimia are more likely to attempt. Not surprising, there's definitely increased cluster B traits in this group. And patients with anorexia are more likely to complete. It's interesting because suicidality does not necessarily improve with illness course. And in fact, it can be sort of inversely correlated because particularly with patients that are underweight, as they start to weight restore, the apathy diminishes, but everything else gets worse, right? Suddenly they have more energy, so they notice they're anxious. They notice that their mood is bad, a lot more irritability. And so some patients I have seen become more suicidal with weight gain. I had one patient tell me that restriction, she really saw restriction as a slow suicide and realized that we had taken that away from her and was just how upset she felt about the fact that we sort of took that option off the table. And then another young woman who's probably my favorite patient of residency explained to me one day that she had to be pretty or die, and being pretty meant being very thin, and that was obviously a long conversation. But all of these issues can kind of emerge as they get better. Non-suicidal self-injury is also really common in these folks, particularly when we take away their option to use the eating disordered behaviors to deal with their distress, because that really is one of their coping strategies, and if we remove that, they reach to the other stuff. There's lots of, cutting, bruising, all sorts of things that these patients will engage in. A couple of things to think about when they're admitted to the inpatient psych unit include being thoughtful about having a care plan that's created by the team and includes the patient with really clear expectations around some of the stuff that's going to be tough. So the things like exercise, like meal plans, stuff like bathroom privileges if someone's doing a bunch of purging, and having a conversation with them early with the whole team involved to be pretty frank and with the motive that, hey, our goal is the same as your goal, which is we want to get you out of here and back on with your life, which hopefully is their goal, but admittedly isn't always. And having an explicit discussion with them around the issues of caloric replacement and talking about engaging them around that. Mealtime, ideally providing some sort of mealtime support. I know with staffing, logistically, we can't have people sit with them throughout their meal. I fully recognize that. But if there could be someone to check in with them, to offer encouragement, to distract them. Again, if we think of this as this is their therapy, right? This is their exposure time, and giving him some support in these situations, because this is the hard part for them. If they could do this on their own at home, they wouldn't be in the inpatient unit. And then record what's eaten and let the team know if they're not eating. I was on call overnight, I don't know, maybe sometime last year, and I got paged at 10 p.m. to tell me that the eating disordered patient hadn't eaten all day. And I was sort of well, it's 10 p.m. And maybe they told the team during the day and the team had just not done anything about it and not told me about it. But it's really important that everybody on the team knows that patient didn't eat breakfast and then didn't eat their mid-morning snack and didn't eat lunch, rather than that it shifts all the way to the evening when I was I don't know. See if they'll eat a snack now, which of course they wouldn't. So I can always be hopeful though, right? Maybe they will now. So what can we be doing for them aside from the meal support? Well, helping them learn skills can be something that we can incorporate into the inpatient unit. These patients have terrible distress tolerance. This is not their forte. And so things like DBT-based skills that we're teaching our other patients can be really useful to them, because they're really using those eating disordered behaviors to deal with these really intolerable feelings. And if we can give them a few other tools in their toolkit that they can start practicing, maybe they can use those rather than all of the eating disordered stuff that they're doing. There's also evidence for like motivational interviewing to improve treatment adherence. So this is a great opportunity to practice your MI skills. Wanted to talk briefly about CBT, because I know that we sometimes do this on the unit, and what CBT for eating disorders sort of addresses. So the original CBT for eating disorders just looked at the eating disorder stuff. That was its whole focus, looking at the eating disorder behaviors and the stuff around body image, which is important, but as we've talked about, isn't really, it's just the tip of that iceberg, right? So more extended CBT for eating disorders, which is actually shown to be more effective, also works on addressing things like perfectionism, low self-esteem, interpersonal issues, poor problem solving, and then this whole idea of low distress tolerance. So if you're working with a patient on the unit, thinking about approaching some of these issues can be really helpful, because a lot of this stuff is actually what drives this stuff up here. And if you don't address sort of the bottom of the iceberg, it's just going to stay there. Wanted to talk briefly about family members, because sometimes we have to engage with them when the patient is admitted. And this is a really tough spot for families to be in. There are a lot of hard feelings around this, lots of shame, guilt, frustration, and fear. There's a high caregiving burden for families, because often the eating disorders start in their teens and last several years. Median illness duration is like 6 or 7 years, so this is really a marathon, not a sprint. And you can get some pretty dysfunctional family behaviors around the eating disorder stuff, because families can unintentionally sort of accommodate and support the eating disorder as they're trying to have their child or loved one like be less distressed, and they do that by accommodating these eating disorder behaviors. And so families really have to learn how to communicate differently and develop skills around this. And I have a couple of resources listed at the end that you can sort of direct family members to. And just to end, I wanted to talk briefly about recovery, because recovery from an eating disorder like literally has its ups and downs. This is not a linear process at all, and it's not a quick process either. But these patients really do get better. So this looks at recovery from anorexia and bulimia. And well, about 20% of patients go on to develop chronic and enduring illness. Some 60 to 80% improve significantly or recover completely. So the majority of these patients do very well and go on to live full, productive lives. But it takes time. So this looks at individuals with anorexia who develop the disorder in their teens. The green line is recovery, and you'll see that it approaches 80% like we were talking about, but only if you actually look 10 years out from the onset of the illness. So this takes a long time, and you may be meeting the patient earlier in that recovery process, and just it's a slow push to get them there. So this is just a list of resources, and hopefully you can have access to these slides. So these are some of the local treatment places that you might hear about. So the Eating Recovery Center is where I got a bunch of my clinical training. It's great.
That's new, isn't it?
So it used to be the Moore Center, which was there for many years. And then ERC, which is Denver-based, bought them out. It's great. They have lovely providers there. They'll actually do free screenings and then help sort of figure out your insurance and where you can go. I do want to say that some Medicaid patients are actually able to get into these programs, which has not necessarily been the case historically, but King County is working on an actual triage system for them, depending on level of illness and where they should really be going. So it's not completely out of the question for sort of our Harborview population, and is something to definitely be looked into. Then there's also Emily Program and Center for Discovery are two of the other ones around here, and there are a few more. And then some websites for patients, parents, and for us, National Eating Disorders, the ANAD, and then the somethingfishy.org is also a good eating disorder website. And that is the end of my presentation. Are there any questions?
Thank you.
Yeah, thank you. Thanks, guys. All right. Get out of here.